Good morning and welcome to Minority Health Month. This is a really exciting opportunity to have a discussion as we enter this time of thinking about the health of our minority communities, to really chat about where we have been, where we are, and where we're going, and how the life that we've been living over the past 2 years impacts where we're trying to get. I'm excited to be here with a really exceptional panel of experts. Before I tell you who they are, I should tell you who I am. I am Dr. Dina Chisholm. I am a professor of pediatrics and public health at The Ohio State University, and I'm Vice President of Health Services Research at Nationwide Children's Hospital. Specific to being here, I'm also a past chairman of the Ohio Commission on Minority Health board, and really happy to have the opportunity to facilitate a dialogue, just a real discussion about minority health, about health disparities, about COVID, about mental health, about all the things that are on our hearts and minds as we enter this time of focus on issues that we know we have to focus on all the time, but we take the opportunity in this month to bring it to everybody else's front of mind. And so we're going to start with a discussion. And before we start the discussion, let's make sure you know who we're chatting with. So I want to start by having everyone introduce themselves. And first, I'll start with our special guest, who's here from not Ohio, and that would be Dr. Kamara Jones.
Hi, thank you. Thank you, Dr. Chisholm, and I'm so happy to be part of this conversation with all of you. I am a family physician and epidemiologist by training, and an anti-racism thought leader and activist in my work now. I am currently in Atlanta, Georgia. I am also the 2021-2022 UCSF presidential chair at the University of California, San Francisco. But as I said, I'm in Atlanta because of COVID. I will be out in San Francisco for about 3 weeks this spring. I also, before I turn it back over to you, want to let you know that I do have an Ohio connection, which is my sister, Dr. Camille Jones, who retired about 2.5 years ago from being the assistant health commissioner for the city of Cincinnati. So I'm delighted to be part of this conversation. Thank you for having me.
Well, we're happy that you're here and happy to know that you have roots right here, or at least family roots right here in the Buckeye State. So let's introduce the people who are with us here in studio, and I will start with Director Chris.
Thanks so much. I'm Lori Chris, Director of the Ohio Department of Mental Health and Addiction Services, and we're really grateful to be part of the kickoff for Minority Health Month. For me personally, it means a great deal. I was an intern with the Commission when I was in graduate school, and so this is my 31st Minority Health Month, and I've just really valued and treasured what this kickoff has meant, what the month and awareness has meant for the state of Ohio and its citizens, and what our department can do in partnership with the Commission as well. So thank you.
Excellent. Director Corcoran.
Thank you, Dr. Chisholm. My name is Maureen Corcoran. I'm the Director of the Ohio Department of Medicaid. And I think maybe because I'm a nurse, the impact of individuals, the 3.4 million Ohioans that we support now in the program, is very much on our minds. And so I really welcome an opportunity to talk about the needs of all Ohioans and the impact and the importance that diversity and equity issues play in the healthcare system that we have.
And Ms. Rowling McGee.
Hi, Dr. Chisholm. It's great to be with you this afternoon, and I appreciate the opportunity to celebrate Minority Health Month with you. I am the president of the Health Policy Institute of Ohio. We're an independent and nonpartisan organization, so we're outside of state government. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending here in our state. A lot of our work focuses on data, so looking at what the data tells us about those who don't have fair opportunities to achieve their full health potential. So this is a great month for us to refresh our focus on data, and then also to look at what works to eliminate disparities and inequities so that more Ohioans can achieve their full health potential.
Excellent. I want to think about, as we're going through this path, the specific issues of minority health. And we can't talk about the specific issues of minority health without thinking about the ways that race and ethnicity impact experiences of health and experiences of life in our society. So before we start talking about a whole bunch of nuts and bolts, I want to take the opportunity to lay a foundation to think about what race, racialized experiences, racism mean in conjunction with Minority Health Month. And I want to do that because I think that we weren't even talking about racism seriously as a predictor of health until the past 5 years, except for Dr. Jones, who's been talking about it for 20, but we're just getting on her boat. But now we're talking about it, we're making statements, we're making proclamations, but not everybody's starting at the same point. So, Dr. Jones, if you could start by telling us what are the key messages that we should think about or know about racism as we have this discussion?
Thank you for that question. I actually think there are 4 key messages when we're talking about racism. The first is that racism exists. And for some, that's a point of contention or a revelation or whatever. So I will come back to that. The second is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth key message is that, yes, we can act to dismantle racism. So coming back to that whole point about racism exists and why I really think that has to be our beginning point, racism denial in our nation is like a huge black hole in our national landscape, a black hole in the same way that we have black holes in the universe, which are massive and powerful, but invisible, right? They're so powerful, they suck things in, invisible, because even when light comes near, it gets sucked in. Racism denial is operating the same way in our country. And even as we, as a nation, either 5 years ago or for many people just 2 years ago, with the recognition that COVID-19 was having disproportionately negative impacts on the health and well-being of communities of color, or with the horrific murder of Mr. George Floyd and so many before him and so many after him, about 2 years ago, people were starting to wake up, that racism exists. But for many, this, racism denial, as we are trying now to intervene on structures, as we are trying to address dehumanizing value systems, racism denial has not been something that we have been explicitly addressing. But racism denial is the thing that makes people grow tired and weary. Are we still, like 5 years from now, I predict that people in our organizations might be asking, are we still talking about racism? I thought we had done that. And what we need to recognize is that, yes, racism exists. Yes, it's a system. Yes, it saps the strength of the whole society. And yes, we can act to dismantle racism, but our actions will not have instantaneous results. We must act urgently now, but our actions with urgency have to be changing the opportunity structures, changing the value assignment, and addressing that huge middle ground of inertia that says this is not a problem at all. We must address the racism denial, even as we're doing our other work, and recognize that our work is going to be over generations, that we will not have instantaneous things. We must act with urgency right now, but it's like this. We need to plant an acorn today so that our grandchildren can have shade. And when we plant, we don't just plant the acorn and walk away. We need to plant it and water it and nurture it and get the weeds out and then maybe plant another acorn over here. We need to be doing stuff in a longitudinal and sustained way. Our anti-racism is a process. It is not a one-time thing and done. It's iterative. Sequential, name racism, ask how is racism operating here, organize and strategize to act. Name racism again, ask how is it operating here, and organize and strategize to act. And we have to be willing to be in this for the long haul because racism is sapping the strength of our whole society.
So we've got 4 key points. I want to make sure I've got them. Racism exists. Racism is a system. Racism saps the energy of our society, and we can make a difference. I think that's where I'm going to start this discussion, and I think that we can build on that. Starting the process of building on that, I want to look backwards a little bit. So I want to look at the past 2 years, let's say. The beginning of COVID, the experiences associated with George Floyd, everything else that's happened in and around that. What have you learned from that experience that's changed the way you work? Whether you learned it afresh, or whether it was just something that was reminded or reiterated to you when you saw it in action in the past 2 years. What's sort of the lesson that you have on your heart or in your career related to what we have been going through over the past 2 years? Director Chris, you want to start us off?
Sure. You know, the pandemic has been really difficult for the mental and emotional health of people around the world, the nation, and Ohio is certainly no exception. And so for our work and our department, these 2 years have been incredibly difficult. And one of the things I've relied on is really that reminder that while we're all in the same storm, we're not all in the same boat. And the kinds of boats we're in are very different. You know, some of us are cruising along on yachts, others are in canoes that have been patched a few times. Some might not even have a boat at all. They might just be treading water. And so that's an image that I've kept in front of us and kept in front of myself. And not just the image itself, but that responsibility to name that when we're moving through decisions, moving through resource, funding allocations or policy decisions or program development, even in public campaigns and reaching people, just making sure that we're really intentionally thinking about who is this reaching, who is it not reaching, and why is it not reaching them, and how do we include that group in helping us get to a better place so that everyone does have not just the opportunity, but the capacity to pursue that opportunity in the first place.
Director Cook?
So I find myself thinking about an old fact or an old lesson and a new lesson in your question. We're very aware in the work we do in Medicaid, for example, about the infant mortality rate and the disparity between African American babies and Caucasian babies, for example. The mortality rate being twice as much for African American babies, and similar disparities for maternal mortality as well. So that's kind of the thing we knew, sort of the old lesson. The new realization is it's the exact same kind of disparity that existed even as we moved into the pandemic. Now, Ohio Medicaid is a very diverse group of individuals, people who are elderly, young children, people with serious mental illnesses. We have a very diverse state and a very diverse group of people that we serve. But we've really had to name and focus on why people on Medicaid broadly, and in particular, individuals who are of an ethnic or cultural minority, why their experience with COVID, with vaccination rates, with death, why are those so different? And we'll talk, I'm sure, as we go about more of that, but the learning, I guess, or the realization was really kind of old story, but new facts, and we'll get into, I'm proud of the work that we've done and the leadership the governor's provided, but that's my kind of realization.
Well, I love Dr. Jones' analogy about the acorn and planting the acorn today, because something that surprised us, although it shouldn't have surprised us, is that while we experienced this moment of hope during the summer of 2020, that there was an awakening or a reawakening to the need to really focus on racial justice, for us all to intensify our efforts in that regard. There has now been a backlash to those efforts. And that shouldn't have been a surprise to us. I mean, racism has existed for hundreds and hundreds of years. Why we thought in one summer all of that would disappear, I don't know. But now we're having to remind ourselves that our job is to plant those acorns, and to continue the work, to be patient and be persistent, and continue to talk about what the evidence tells us and what the data tells us, not to back away from these hard conversations that make us feel uncomfortable many times. That has been something that was a surprise to us, and something that we're continually learning from in our journey.
I want to add one more thing, Amy, just building on that is, I think the other thing that it really reminded me of in the best of ways is that shade that we're sitting under today because people planted acorns before. And the shoulders that we stand on in the work that we're doing today because people remembered to name things that needed to be called out, remembered to ask the questions of who was getting left behind and reach behind and make sure that they were, coming along. And that was something that was really powerful for me and that I saw among our team and among the cabinet members, our colleagues, and through the leadership of the governor is really reaching out and building on those successes and acknowledging the importance of the history that we're standing on that's brought us to this moment and that gives us the strength to carry on as well.
That is such a refreshing thing to say, let's look at the history, let's remember the history, let's understand that we're part of the historical stream. And one of the things that's really hit me is that this nation is very ahistorical typically. And in fact, right now, that there are people who are actively campaigning across many states in this nation to suppress parts of our history. And there are people who may think that they got where they got because they worked hard, right? Because we have this myth of meritocracy. If you work hard, you will make it. And which makes them think that the other people who haven't made it haven't worked hard, that they're lazy or stupid. There's so many parts of our culture that don't acknowledge that are actually barriers to achieving health equity, I would say. If I could just list 7 and then go into the one that made me go like, oh, the ahistorical. The fact that we're narrowly focused on the individual in this country, that we're ahistorical, we have an ahistorical stance. The fact that we endorse the myth of meritocracy, the fact that we endorse the myth of a zero-sum game, the fact that we have a limited future orientation, the fact that we endorse the myth of American exceptionalism and white supremacist ideology are 7 kind of cultural or societal barriers to achieving health equity that are standing in our way. So even as you're acknowledging history, which we all should, and we should all want all of us to learn all of our full histories, that ahistorical stance that acts like the present, we're disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance, is actually a huge barrier. It lets people feel that it makes people feel entitled to what they have, that their state of being is normal, especially if they've been structurally advantaged. And it makes people miss the fact that there's a system going on that is unfairly disadvantaging some but every unfair disadvantage has its reciprocal unfair advantage. It makes people miss that point, and they think instead that, yeah, there's some disadvantaged folks, and yeah, there are two states of being going on, but it makes them describe the two states of being as being disadvantaged and normal. And the reason that so many in this country think there are two states of being, disadvantaged and normal, is that we're ahistorical, that we act as if the present were disconnected from the past, as if the current distribution of advantage and disadvantage were just a happenstance. And those people who understand their current experience to be normal don't recognize that their whole normal, so-called normal, is built up on a whole mountain of unfair advantage. So I guess I was so appreciative of you calling up history and recognizing the history in our work. But so many of us are ahistorical, and that's, I mean, how do we address the ahistorical aspect as we're trying to address health equity? Do we incorporate history in all of our meetings? Do we write the histories of our organizations? Do we teach history in Saturday schools? Do we push against the anti-CRT efforts to insist that everybody learn our full histories? What is the role of history in our work? Sorry, Dr. Chisholm, I know you're the moderator, but
You are allowed. This is a discussion. I am just the traffic cop, and so far you are not exceeding the speed limit, so you're good. But I want to build off of the idea of history or our ahistoric approach to a lot of things, and ask some of our state leaders and state thought leaders, when you think about history, whether we're talking about recent history or longer history, what are the strengths and weaknesses that our approaches have experienced in being able to address health equity issues? So when you think about, we're living in a history, we're living in a present that are steeped in everything that happened, over the past 400 years or so. How has that history generated strengths or weaknesses in the spaces that you work that make it hard to address health equity?
Well, I'll share a strength and then also a weakness. So several years ago, Ohio made the decision to expand Medicaid eligibility levels so that more people would be covered by Medicaid. And Director Corcoran can talk more about that. What we've seen is since that policy change was made, we've had vast improvements in healthcare access in our state. So whether it be looking at the uninsured rate, that's gone down, actually being able to access a provider for services when you're sick or you have an accident or injury, all of those measures have improved. So what that tells us is that when we embrace a policy change, we can see an impact from that policy change. Policy change does make a difference, can make a difference. And there's countless other examples of that. That's just a very, very large example of something that's had a tremendous impact. But when we look at other states that do better than us, Ohio is ranked 47th on health value, according to a dashboard that our organization produces. And that means that there are many other states that are doing better in terms of health and that are spending less than on healthcare services than Ohio is. What those other states have done is focus more upstream and addressing the root causes of poor health and healthcare spending. So that means looking at all of the other systems and environments that impact our health, like housing and education and whether we have a job that pays a decent wage, all of those other factors, and investing in our public health systems. Mm-hmm. In Ohio, historically, we have not invested enough in prevention and public health. And that has an impact today in terms of our health and our healthcare spending. So that's where we need to focus attention going forward. But we have had successes in the past, which we've achieved through policy change.
I want to take it from a little different angle, and it really goes, Dr. Jones, to your point about denying racism. I was with the Department of Mental Health for 10 years, and in studying some of the history of psychiatry, nobody denies the impact that the differential impact on women as psychiatry evolved, and the ways in which women were, and their experiences were looked at through the lens that was in some ways very similar to what we're talking about here from a racial or cultural perspective. So I find myself thinking, you know, anyone who has experience or knowledge in that arena wouldn't deny for a moment the impact that the earliest years of psychiatry had on women. So in many ways, our healthcare system has lots of examples of that. And it doesn't make me ashamed. It actually, you know, makes me, particularly, I guess, growing up as a nurse, you know, it makes me feel like, okay, this is what we're here for. We can acknowledge our history, we can make the changes that are needed, but we have to acknowledge the ways in which the system has not treated every human being to their fullest potential.
From a strength standpoint, I think that historically we've had a very community-driven approach in Ohio, which has really created the opportunity for local communities to identify needs and to close those gaps at the local level. And there's a strong relationship between the state level policy and resources and that local community planning. And I would say that we're building on that strength very intentionally right now in our department, and helping to support that local planning and to better use data to understand that weakness is where I would, you know, emphasize is that we haven't used data for planning, and data in the behavioral health world hasn't been very strong on a national level. And so more emphasis about how to better use data to really create more opportunity and invest in that more, so that we are not just looking at those top line numbers in terms of, you know, the trajectory. And I'll use suicide as an example there. Suicide rates in Ohio and nationally have been declining over the past 3 years. They've been dropping in terms of death by suicide. But when you dive deeper and really look at the numbers, that's not true for Black men. And that's not true for men between the ages of 20 and 24. And that's not true for older adults either. But if you just look at that top number, and we've done a lot of strategic work in suicide prevention, and a lot of good is coming from it. And we're doing strategic work with Black men too, but we're not there yet. So that just gives us that drive to do more, to do things differently, to look at how to better reach and close those gaps and reduce those disparities.
I think that's a really great statement, and I'm going to say this based in my own bias because I'm an epidemiologist, so numbers make me happy, thinking about data makes me happy. Recognizing that data is one way to understand history, and being able to drill down, being able to look at subpopulations is a formal way of being able to understand the impacts of histories. So, you know, you wouldn't necessarily call an epidemiologist a historian, but sometimes that's one of the things we get to be in our spare time, which is fun. But it also allows us to really understand how historical slights, historical injustices can have and continue to impact the health of minority population. So thank you for sharing my favorite thing.
What if people don't care about Black men? What if people don't care about old people or those 20 to 24? You know, what if the data, what if they blame those people for the, for their statistics? How do we change the caring? You know, what is required for us to value all individuals and populations equally? what's required for us to recognize and then rectify our historical injustices, and what's required for us to provide resources according to need if people feel fine with the aggregate number or glad that they're not being adversely impacted. Like if it were their group, then they would say, oh, we need some resources over here. But if it's some other group, then they're just fine with inaction, lack of action in the face of need. So how do we move the voters, the taxpayers, the leaders to want to care about all of us? How do we, this is a real question. This is not a rhetorical question. Like how do we center the margins? You know, sometimes people talk about centering the margins. How do we do that? How do we care that?
That's a great question. I know that myself, I know Amy, we spend a whole lot of time generating numbers, trying to change hearts, but how do we do that? Is the numbers what changes hearts? Is it something else? What do you guys think?
Well, I mean, we're doing that through our community planning process, and this is something that we've been in the process of updating for the past 3 years. Our community planning process it's a requirement. So, you know, I think it's been largely approached as meeting a requirement. And the vision is that it's so much more than that. It's actually improving the lives of Ohioans through strategic efforts using data and other, you know, community input to create that community plan at the local level. And so revising how we approach that, using data in the plan, aligning it with the same timeline as the state health improvement plan and the state health assessment so that community partners at the local level can work together, and then at the state level we'll have that information in a way that makes sense. Looking at how we can do that with other parts of the health and human services system that are really helping to move the needle, I guess. Thinking about who needs to care, the people that need to care are the people that are responsible for resource allocation and program development at all levels, you know, not just in government, but in the private sector too. And by convening those opportunities, creating a big tent for all voices to be present, to be partnering, and to take responsibility together, that's how we'll move the needle.
I agree with that. I think that, you know, part of the challenge is how do we get away from othering? You know, how do we start to believe that somebody who's not like us still matters on this planet? Mm-hmm. I don't know the answer of how you do it. Part of it is, you know, this whole concept of diversity and inclusion. Mm-hmm. And I know that it sometimes becomes a checkbox. But the idea of when you interact with other humans who may not look like you, may not have the same background as you, financial background, educational background, regional background, and you find out that they have a lot like you and a lot that's not like you, but that's kind of interesting and you'd like to know a little bit more about, they become people and not just them. So when we're putting together these systems that say, let's find ways to diversify, not just diversify so that we can have a picture with multiple different looking people in it, but to truly include people in meaningful discussions and engagements, creates opportunities for people to see each other as human. Mm-hmm. And the more we see each other as people, the better chance there is of us caring about one another, not just the group that represents us ourselves. Now, of course, I'm the moderator, so I'm not even supposed to be having these discussions or having opinions, but, you know, we're having fun. We're having a discussion.
But I think it's absolutely right. I think it comes down to relationships. Like, no plan, no document, no set of data, no research brief, none of that will make any difference if we don't have relationships with other people and work in partnership and collaborate with other people. And that means, like, all of us having uncomfortable conversations with people too. People who don't agree with us, and listening, you know, just sitting and listening to people, and listening to their perspectives and not always being caught up in making the next point or winning the argument. And I'm saying all of this with full acknowledgement that I've been guilty of all of these things too. It's something that I am always working on, but I find that every time a success is achieved, it's because there was a willingness to listen and there was a relationship that was built over time.
So before we're done, I really want to talk about the future. But before we get to the future, I want to give everybody a chance to crow about the present. So I want to give each of you an opportunity to tell me what's the one thing you've done in the past 2 years that was directed at improving equity that you are most proud to say you've done in your organization. So whoever wants to jump in first.
I'll jump in there. One of the things that we set about doing was making sure that we were inclusive, and not just in conversations and in planning, but in really thinking about how we allocate funding and being more inclusive of those organizations who really reach minority populations in Ohio, but wouldn't necessarily have considered themselves a partner with our department. They wouldn't have even perhaps thought of themselves as part of the mental health and addiction services system. So community-based organizations, faith-based organizations, and folks who really operate within a community and are closest to the good things that need to grow and can most easily see the gaps that need to be closed. So we've taken an intentional approach of having funding that is allocated to community partners who operate in communities throughout the state. We've partnered with the Commission on Minority Health to share resources there for them to allocate. The Governor's Office of Faith-Based Initiatives is the same. We're also working with the Hispanic Commission. And we're also direct funding partner organizations that are reaching minority communities throughout the state in a way that our traditional partners may not have had those relationships and inroads.
So Director Corcoran, what are you most proud of?
Somewhat like what Lori's talking about, we began a process in 2019 to really revamp the entire Ohio Medicaid program at the request of the governor, and began a process of going around the state, meeting with community groups, working with community-based organizations, doing facilitated interviews of consumers, of individuals served by the program. We got more than 1,100 very thoughtful pieces of written input from people across the state. And what the simplest thing, but the thing that I really am most proud of is, as we began then to put the request for proposals together, to put the procurement out, the number of people who came to us and said, I see that you listened. Not just I know you listened, but I see here how you listened to what we were saying and made a difference. And the first 2 or 3 people, I thought, well, they probably talked to each other or something. But after then, a couple of dozen people, and people who I knew didn't talk to each other, it was just, I was very proud of that it got across to people that we really wanted to hear, to listen and to hear and to make a tangible change that people could see. And so that is, as small as it is, it was very powerful for me.
Well, and I would say that I'm proud of the fact that our organization has remained steadfast in highlighting the data and also highlighting evidence. So just to share a few pieces of data, since I know you love data so much, 25% of Black Ohioans report having experienced physical or emotional symptoms due to treatment based on race. That's compared to just 4% of white Ohioans. 1 in 10 Black children in Ohio is treated unfairly due to their race. That's 17 times higher than white children. So those are both examples of experiences with individual level racism. But then taking it another step to the systems level experience, nearly a quarter of Black Ohioans are severely housing cost burden compared to just 10% of white Ohioans. So just to bring that all together, the neighborhood where Director Chris and I live, which is just a couple of miles away from here, here in Columbus, Ohio, was originally settled by a Black man named Pleasant Litchfield, who was a blacksmith. And he developed that land, he farmed that land, raised his family on that land. He established a family cemetery there, a school. He was foundational in establishing one of Columbus, Ohio's first Black churches. Several years later, so this was in the mid-1800s, in the early 1900s, the land was acquired by some white developers who put in place racially restricted covenants so that the land could not be owned by anyone in whole or in part of the Negro race, according to the language that was in the deeds. And this is still in the deed to my house, so I have the proof that that happened. And you can see that manifest itself today in the fact that the community is still predominantly a white community. So we know that those historical injustices continue to have present day impacts. And those present day impacts continue to have impacts on health and our health outcomes. So we need to go upstream and deliberately address those root causes and those injustices that have persisted.
Excellent. So we're proud of work we've done in funding community organizations, in listening to the community when we develop our approaches to funding, in generating information that can be used for making good decisions, and also learning a little bit about our own world and our own lives and applying that to understanding what it means for health in the long run. So we've got a lot to be proud of. We've done some meaningful and valuable things, but now it's 2022. And it's time for us to think about what's next. So I want to start with Dr. Jones and say, what's on your mind? You know, listening to everything that you've heard so far, thinking about what's going on in your brain, unrelated to what you've heard so far, what are you thinking about right now in terms of health equity and in terms of race and health?
I am really thinking, seeing some of what was described earlier as backlash, fatigue with the anti-racism work, even thinking about people who are living in your communities with the racial covenants and the present day manifestations of long histories, and what it would take for those communities to think, well, how would we become different? It makes people uncomfortable perhaps to move out of what they have come to consider their entitlement and their norm and the like. So I've been thinking about a tension in our workplaces, in our communities between two values. Those who value comfort, and at the polar opposite end, those who value social justice. And just to give you a very brief idea of how we can think about these, those people who value comfort because they're comfortable in the status quo. They're like people who are sitting inside a restaurant at the table of opportunity eating, and they look up and they see a sign that says open. They were born in that restaurant. The sign has always said open, and they don't even recognize that it's a two-sided sign. And just on the other side, it says closed. They don't know that because they don't even wonder, why aren't other people coming in the restaurant? They don't feel like they're missing anything. They heard tell, somebody said maybe there was a two-sided sign going on, but they didn't even want to disturb themselves, or certainly not their children, to learn, is there really a two-sided sign going on? They're just fine. On the outside are the people who value social justice, and they value social justice for two reasons. They do know that there's a two-sided sign going on, saying open to some, closed to others, and they know that that sign is sapping the strength of the whole society. How do they know there's a two-sided sign going on? Well, some of them were born outside. They saw the closed, but they could look through the window and see people inside eating. Although there are some people who were born inside the restaurant who wondered, what are those people saying outside? Black Lives Matter. Why are they saying that? And they went out and they saw, or they wanted to burst through their bubbles of experience, or they read widely, or there are other things that they did. So where you're born doesn't say what you have to value, right? In fact, there's some people who were born seeing closed, found their way in, and don't want to keep the door open for others to follow them, right? So what I'm not saying, you're not destined to be valuing comfort versus valuing social justice, but you can't do both in the current day under the status quo. And what I'm saying is that we need to move more of our population, more of our colleagues at work, more of our people in our schools from valuing comfort to valuing social justice, knowing that when you value social justice in the current status quo, you will not be comfortable, but recognizing that for all of us, the edge of our comfort is our growing edge.
So that's a great segue to what I'm going to ask next, because I want you guys to put on your blue sky hats. I want you to think about what is the policy innovation, the strategy in your space that would possibly make folks uncomfortable, but have a meaningful impact on health equity. When you think about what you're doing, what you have done, putting that behind you, think about what you could be doing and what you should be doing, even though it might be uncomfortable. What's the innovation that you would love to be able to see happen?
Well, I can speak to right in front of us. You know, we're on the verge of implementing massive change in our Medicaid program. We've had the same structure in our program basically for more than 15 years and have undertaken this process of listening and creating a new program. And to the point that Dr. Jones made earlier, you know, we listened to the experience of the individual. We made a commitment that it would be focused on the individual, the person, not the business of the managed care plans that we work with. And so now what we are beginning in our rollout is an entirely revamped program that has, and I have 4 pages of notes of all the ways in which health equity has been woven through the entire new design. So it's not just Appendix S where we talk about quality, where, you know, my firm belief is you cannot have quality without equity, but it's not just about that section. It's about every section of the program. It's about communication, it's about work with members, it's about work with providers, it's about access to services. And so, you know, what I'm excited to see is how we bring this to life and have issues of community and of equity to be woven throughout, from top to bottom, every aspect of the program. That's the systemic change that we have great hope to see realized.
And have you experienced or seen others experience the tension or the discomfort that is associated with making those sorts of changes?
You know, honestly, no. Not with our managed care partners, not throughout the department, not throughout literally the thousands of providers and families and organizations. You know, I do think that having the focus be on the individual, their experience, their history, their needs, has been a real unifying theme. And so we really haven't. Now, we haven't put it all into place yet. But no, in laying out the vision, I have been just thrilled with the degree of support and commitment that every one of our partners have expressed, and everyone realizing what a big lift this is going to be. I mean, nobody is saying this is going to be easy, but everyone has said to me, we're committed to making this real.
Great. What about you, Director Chris?
So relying again on data, and I just have to keep going back to that and helping us make decisions that are strategic and targeted to those Ohioans who are most negatively impacted by the current landscape. And an example of that is overdose deaths. So I already talked about suicide deaths. Overdose deaths, we are working very closely with the Department of Health to monitor overdose deaths in the state of Ohio. And what we've been able to see is that fentanyl has taken over. So the opioid crisis has moved from prescription opioids to heroin to now fentanyl. And in that transition, Black males have started dying at higher rates than they have previously. And other races and ethnicities have had their highest peak year of deaths in years prior to 2020. But for Black males in Ohio, 2020 was the deadliest year for overdose deaths. And by using that data, by keeping it in front of us internally on a regular basis, monthly basis, we're looking at this. This is just part of the reality of what we have to help turn around. And then using that in partnership to have strategic initiatives like naloxone distribution. So we've always made naloxone, the overdose reversal drug, available to all 88 counties. That's part of what we do in our department as the state's pharmacy. We do that in partnership with the Department of Health. But this year, we've worked together to look at not just which counties have the highest overdose death rates, but which neighborhoods, which zip codes, and how do we engage lay distributors of naloxone? So not just, the professionals who are out in the field distributing it, or places that people go to get it if they need it, but community members who know where people who are using drugs and are at risk of overdose death are, who have a relationship already, really engaging that, making it more available in those local neighborhoods. That's an example of how we can take data to help inform our policies and practices, and then actually the implementation. And for me, that will just inform more data to help us continue. It's that loop, right? To help us continue improving that over time.
Well, and I can't wait to see all the implications of the crisis work that Director Chris has been doing. I mean, think about from the healthcare system, and we know what the crisis element of that is in communities, in emergency rooms, policemen on the streets, and the work, the thoughtfulness, the dialogue, the engaging of communities to really be able to articulate for Ohio a crisis system that I think that is just phenomenal. I can't wait to see how that, and to be helpful in making that, not just watch.
Right.
Yeah,
She's
we're going to
not
help.
just watching,
We're going to help.
Yeah, well, and I'll talk, thank you. That was lovely. I appreciate that. And there is a tremendous amount of work going into that. So 988 is the new 3-digit number for the 10-digit National Suicide Prevention Lifeline that will go live in July of this year. And across the country, most states are looking at how do they just turn on 988? How do they flip the switch from one to the other? And from the very beginning, we've looked at this continuum of crisis response. So one of the reasons people don't get care is that they don't know where to get care. Another would be that they don't know how to pay for care, or that they feel stigmatized or embarrassed. Fourth would be that they don't trust the system. So we have a number of efforts in place to help create easier on-ramps, more visible on-ramps, less stigmatizing on-ramps into the behavioral health system. A place to call, 988 being the first, but then mobile crisis for people of all ages in all communities to be able to get help where they are in community that may partner with first responders, because that might be what's available in that community, but it's not a criminal justice response. It's a healthcare response. Right. And then crisis stabilization centers and behavioral health urgent cares are growing across the state as well. So people can go to where they are and get that help that's specialized for mental health and addiction crises. But the overall goal was really to help people thrive in community. We want people to not continue to cycle through crisis experiences. We want people to not be in institutions like psychiatric hospitals or jail or prison because they have a mental health issue or an addiction, or because they're a community that doesn't have access to care, or because they've had bad experiences when they have, based on maybe they don't see people like them in the workforce, based on race and ethnicity. They don't have someone who speaks their language. So really working to grow the workforce and help create those opportunities for people to be well and stay well in their home and in their community with the support of their family and neighbors.
Excellent.
Yeah.
Amy, what's your blue sky or your horizon?
Well, I love what both the directors have said. I think we can all agree that we want Ohio to be a model of health, well-being, and economic vitality. And we want everyone to have the resources they need in order to reach their full health potential. We care about the end result, and we're investing lots of money into our health and human services infrastructure. So we owe it to ourselves as taxpayers, and we owe it to all the other taxpayers to make sure that the investments we are making are at the right time and in the right place in order to enable everyone to reach their full health potential. That's why I love what the directors both said, because it's not just about flipping on a switch or making a program available to people. It's about looking at whether that program is having the desired impact, asking ourselves questions about, well, is it that we need more time for this program to evolve? Is it how we're implementing it that's making a difference? Or is this something that's just not going to work in this particular circumstance and we need to move on to something else? I think these directors are willing to ask those hard questions and make sure that we're stewarding those taxpayer resources well, so that we do become a model in Ohio.
Okay, so I'm going to wrap up with one last question. We're here because we're kicking off Minority Health Month. April is Minority Health Month. Every year we spend the end of December making out our resolution list. What is our New Year's resolution? So I'm going to ask you about your Minority Health Month resolution, which doesn't have to only happen in April. It can last the entire year. It can last more than that. But what is your resolution, either personally or professionally, that is targeted at achieving health equity in Ohio, or for Dr. Jones and our community more broadly, and our nation more broadly, and our world more broadly, unless she wants to talk about Ohio too. But this wasn't a question I told them about ahead of time, so nobody's prepped. They're coming right off the top of their heads. What is your Minority Health Month resolution? Anybody want to go first?
I commit that I will listen, and I will continue to listen. And I commit that as we take this new program and all these many ways that we have tried to be explicit about positively impacting the health care of all of the people that we serve, but in particular areas where there is great disparity, that we will pay attention to those, we will be accountable for those changes, and we will not be hesitant to say where we've succeeded or where maybe we haven't measured up in this significant change.
So for me, I guess I commit to continuing to ask deeper questions and seek deeper meaning from what on the surface appears to be in front of us. And for me, that's really asking those next level questions. It's not just enough to say, who's benefiting from this, who's not benefiting from this, but really, in getting the answers, asking myself, is this true? Is this really true? Is this really, really true? Really digging deeper into that moment, and to doing that with our whole team. We've got 2,800 staff at the Department of Mental Health and Addiction Services that are connected to direct care opportunities for men and women in the state of Ohio particularly. and who are supporting direct care and planning and prevention, harm reduction, treatment, and recovery. And so continuing to really take the responsibility to lead them in asking those next level questions too.
I commit to leaning into the discomfort, this discomfort associated with having difficult conversations about racism and other forms of discrimination. I think we all have the tendency, or at least I should speak for myself, I have the tendency that the minute I start feeling that discomfort, I start to back up a little bit. I think it's an important time to allow yourself to feel what you're feeling and ask why you're feeling it, and spend some time thinking about that and what that means in that particular situation.
Okay. Dr. Jones?
Wow. You're going to have it on tape.
Yes.
I guess I commit to recognizing my mortality more immediately in my actions. So that means writing my books. It means being even more intentional than I am about mentoring other people. I think about barrels of batons, like you have a baton, you pass it back in a relay race. I think about barrels of batons, and I'm just passing lots back, that I have to bring even more young people around me. I'm not planning to go anywhere anytime soon, folks, but to recognize, so many of us are so much in the struggle, and we think that we have all the time in the world, but time is our most valuable resource. So I think I need to think about what can I leave that will still be here after I'm gone. So I guess that. And I also wanted to commend you all. As I was listening to the things that you all are doing and that you're proud of, all of you were about bringing different people to the table, listening deeply to people, asking questions, valuing other voices. And I just want to say that who's at decision-making tables and who's not is perhaps the most important thing, because who's there determines what's on the agenda, who's there determines the values that are infused. And so I just want to encourage Ohio, and under your leadership, if Ohio is full of leaders like you, amen, to keep doing the inside-outside strategy, but especially to make the institutional walls more porous, to make it easier to get the input. And I was wondering, it's just a question, I know we're about out of time, but in all of your work, I know that Ohio led, you were very early on in terms of states with jurisdictions that were making declarations that racism is a public health crisis. And how important is that in all of our work to make the declaration? How important is it to go further to action? And I know we don't have time to do that, but it's just in my mind, I think it's important for us to name racism and to not back off of that and not 5 years say, oh yeah, we're talking about all of disparities or all of equity or whatever, but to be explicitly anti-racism but is that sufficient? And without the investments that I've heard you guys talking about, and the listening and the invitation to join other decision-making tables outside of your agencies, and also to invite people in, I think that recognizing that racism exists, that racism is a system, racism saps the strength of the whole society, and that yes, we can act to dismantle racism. Those are important things. We have to get off of the naming and move to action. I'm impressed. That's all I want to say. So that was a big ramble. So sorry for the big ramble.
No apologies needed.
Thank you
Any
so
other
much.
thoughts? Okay, so I guess I have to come up with a commitment too. I'm not allowed to just ask the
that's
question
right. You
and
do.
not come up with one myself. And mine is one that I'm going to ask everyone else to join in, because as much as we as professionals think about what we do for society writ large in terms of minority health, I have to also think about what I do for me in terms of minority health, in terms of my health. So my commitment is to be serious about health, be serious about eating, be serious about fitness, be serious about convincing the people around me to be serious about those things at the same time, about telling people about why they should get vaccinated, about telling people about why precautions still matter, about choosing to take precautions that are going to maximize my health, the health of my family and my friends, in a way that maximizes the health of the population, because we have to work at both levels. We have to work at the system level, we have to work at the society level, but we also have to work at the individual level to be our best selves. So my commitment is to put full energy at both ends of that spectrum, and to help other people do the same thing. And to, as Dr. Jones said, bring everybody along. Throw the whole barrel of batons over the shoulder every chance we get to make the circle bigger. Because once we get everybody in the circle, we can then start hopefully moving in the same direction. And that's what we do in Minority Health Month, is take an opportunity to bring everybody closer to the circle so that we can move in one direction, which is towards health equity. I thank you all for your time. I thank you for spending this morning with us. Hopefully one thing you heard made a difference. Hopefully one thing you heard made you think how we can be better, how we can be a healthier society that doesn't have gaps that are based on who you are. Thanks again to Director Dawson, the Commission on Minority Health, to this amazing panel of fantastic women who are leaders and thought leaders. And I wish you all a happy Minority Health Month.
Thanks so much to Dr. Kamara Jones, Director Lori Chris, Director Maureen Corcoran, President Amy Rowling McGee, and our moderator, Dr. Dina Chisholm, for giving us such an honest and deeply provocative discussion on the need to address and eliminate racism as a pathway to achieve health equity. This panel was comprised of national thought leaders, policy leaders, research leaders, as well as the heads of our state cabinet level health and human service agencies, who were gracious enough to share their wisdom with us. Minority Health Month was designed many years ago to bring awareness to the myriad of issues that directly impact the ability of minoritized communities to achieve optimal health. Based on our experiences with COVID-19 and ongoing discussions about race and racism, this discussion could not have been more timely. Of the many factors that contribute to health disparities, structural racism lies at the center, perpetuating unfair opportunity structures which lead to challenging social determinants of health that cause a disproportionate burden of disease and death, especially for minoritized groups. Health equity is achieved when we assure that everyone has a fair and just opportunity to be healthy. This requires removing systemic barriers to health, such as poverty, discrimination, and their consequences, including lack of access to good jobs, quality education, housing, safe environments, and high-quality health care. I extend my sincere thanks to our panel members, whose candid conversation highlighted the opportunities and challenges to create system change, address systemic racism, and achieve health equity. Today's panel discussion focused on the significant ubiquitous effects of racism in every facet of our lives, especially on the health of Ohio's racial and ethnic minoritized populations. We were also reminded that racism diminishes the strength of the entire society, negatively impacting everyone. All panelists provided multiple examples of health inequity, which of course are health disparities resulting from many forms of social injustice. Our panelists came to this discussion with hard data to help us understand the magnitude of the challenges before us, as well as the opportunities to achieve health equity through a variety of initiatives. One thing that all panelists made perfectly clear is that we still need key policy strategies to dismantle systemic racism. The panel members reminded us that we must have the courage and work daily to educate on the connections between racism and health, highlight unjust historical and modern-day policies and practices that have led to a cascade of consequences that limit opportunities for good health for communities of color. Invite those who are impacted to the table and listen to their needs and be responsive. Allocate resources over a protracted period of time in proportion to the need, and implement strategies, evaluate, and make adjustments when needed. We commend Health Policy Institute of Ohio's release of the Health Policy Fact Sheets that educate state and local policymakers, private sector organizations, as well as individuals and community groups on the connections between health and racism. Every Ohioan benefits when Ohio is healthy and economically vibrant. Though all Ohioans deserve the opportunity to be healthy, stark differences in health outcomes signal that not every Ohioan has a fair opportunity for good health. HPIO's 2021 Health Value Dashboard ranks Ohio as 47th in the nation for overall health value and highlights health disparities experienced by Ohioans of color, regardless of income or education level. We know, especially after hearing this discussion, that we can do better. There are questions that need answers, and policymakers have an opportunity to take action to support the health of all Ohioans. Why is action needed? Ensuring that every Ohioan has a fair opportunity to achieve good health and well-being is a shared value in both the public and private sectors. However, Ohioans of color continue to face barriers to health where they live, work, learn, play, and age. Allowing these barriers to continue to exist will only result in a more economically unstable and unhealthy Ohio. And what are these barriers? In Ohio, we continue to see the widening gaps in health disparities and health inequities for racial and ethnic populations. These inequities are evident when we examine infant mortality rates, maternal mortality rates, the opioid epidemic, lower life expectancy, and the disproportionate burden from diseases such as cancer, cardiovascular disease, and diabetes, which are all at unacceptable levels. How will we know when we get there? Our panelists provided a great deal of data to help characterize the magnitude of the problem when, for example, in housing affordability, when 68,009 Black Ohioans and 7,143 Hispanic Ohioans would not spend more than 50% of their income on housing, we are leveling the playing field. Or when 13,373 Hispanic children and 58,507 Black children would not experience food insecurity, we are leveling the playing field. These attainable opportunities exist across multiple areas that connect social determinants of health, those essential resources that impact health. Government can also play a strong role in educating, encouraging, and creating opportunity for public and private sector partners to take action. The Commission stands ready to partner with efforts to get all populations to healthy outcome goals. What can government officials do? How do we move from declaration to determined action? State and local governments have both an obligation and an opportunity to lead the way to improve health outcomes for all Ohioans. As state and local policymakers, we can engage with our constituents, join efforts with other public and private partners across healthcare systems, businesses, universities, payer systems to make a difference. In 2020, Governor Mike DeWine acknowledged that racism is a public health crisis and released a plan of action to advance equity. This action plan has been initiated, and this plan provides both a challenge and an opportunity to examine our state system and commit to make continuous changes to advance equity. Regular, transparent reporting of these efforts can encourage constituents and public and private partners to stay engaged in equity work. HPIO has outlined the following action steps that state and local policymakers can take. Acknowledge the effects of racism on health. Examine internal policies and practices and seek opportunities to dismantle unjust policies and practices. Create a policy agenda and plans that increase equitable opportunities for good health. Recruit, support, and promote diverse leadership and staff. Educate, train, and support staff and leadership. Conduct assessments of proposed policy to ensure they don't negatively impact the health of Ohioans. Authentically engage and tailor policies towards and allocate resources to support Ohioans of color. Because health is not a one-size-fits-all. And this means ensuring that all communities get access to the resources and the services they need for good health. And finally, collect and report data broken out by categories like race, ethnicity, language, age, and disability status to track progress towards creating a healthier state. Efforts to achieve equity have already begun. Both state and local policymakers have collaborated on decisions that address disparities in infant mortality. However, our efforts must be flexible to expand and adjust until we are able to get all populations to Healthy People 2030 goals. What lessons have we learned from the pandemic? And how can we foster these new partnerships and implement intentional strategies to address other health disparities? Continued focus, effort, and investment are necessary from all sectors, both public and private, to ensure that Ohioans have the opportunity to reach their full health potential. Ohioans of all ages, races, ethnicities, incomes, faiths, political parties, and areas of the state can take meaningful action to eliminate racism and improve health. We thank each of the panel participants for sharing their insights, lessons learned, current efforts, and recommended strategies to achieve equity. Their sharing has provided us examples of the work that has been initiated, as well as the work that is yet before us. What is your role in ensuring and advancing equitable opportunities for good health? How can you use your power and influence, your voice and experience in the systems where you live, work, play, and age. Remember, if you want to move mountains tomorrow, you must begin by picking up stones today. Let us work together to achieve health equity. Happy Minority Health Month.